What I'd like to do is, as we move into the panel discussion, we will be speaking with folks who are clinicians who have advised patients in PFAS exposed communities. And it would be great once I introduce you, if you have a reflection on that presentation. I do have some questions, and as you saw with our first panel, there will be many other questions to respond to. So our first, the first panelist I'd like to introduce is she's now Dr. Katie Huffling, who recently earned her doctorate in nursing practice. She is also a certified nurse midwife and the executive director of the Alliance of Nurses for Healthy Environments. With the Alliance, Dr. Huffling works with nurses and nursing organizations to elevate environmental health issues such as climate change, toxic chemicals, and sustainability in healthcare amongst the nursing profession. In 2020, she was appointed as a member of the US EPA's Children's Health Protection Advisory Committee. She is also the reproductive health consultant for the Region 3 Pediatric Environmental Health Specialty Unit. Dr. Huffling was an editor of the environmental health e-textbook, Environmental Health in Nursing, that won the 2017 American Journal of Nursing Book of the Year in Environmental Health. Our second panelist is Dr. Stuart Reed, who earned his medical degree from the College of Physicians and Surgeons at Columbia University in New York City, and then completed internal medicine training at Cedars-Sinai Medical Center and the VA Greater LA Healthcare System. Prior to his medical training, he studied philosophy at the University of California, Berkeley, where he graduated with distinction. His interests include primary care, patient advocacy, medical education, and helping people recover from addiction to prescription drugs. In his free time, he enjoys traveling, reading, playing tennis, and spending time with family and friends. Our final panelist is Dr. Maida Galvez, who is an environmental pediatrician at Mount Sinai in New York City and professor in the departments of environmental medicine and public health and pediatrics. Dr. Galvez works to translate research into programs and policies that prevent and reduce environmental exposures for children, their families, and their communities. She is founding director of the New York State Children's Environmental Health Center, the first statewide publicly funded model for children's environmental health services in the U.S., and since 2006 has served as director of the CDC EPA-funded Region 2 Pediatric Environmental Health Specialty Unit. This unit serves New Jersey, New York, Puerto Rico, and the U.S. Virgin Islands. Dr. Galvez also leads several Sinai initiatives to bring researchers together with community partners to work on environmental health and environmental justice issues. Dr. Galvez is a member of the Institute for Exposomic Research at Mount Sinai, co-chairs the communications work group of the CDC APHA National Environmental Health Partnership Council, and serves on the board of Children's Environmental Health Network and on the advisory board for Parsons New School Healthy Materials Lab. I welcome all the panelists and would like to just open it up. There was so much good information from Dr. Duckerman, but I think it'd be really, really helpful for us to hear from the clinician's viewpoint what your own experiences has been. And it looks like Ellen is back. Welcome back, Ellen. That was a great presentation.
Thank you. What happened is tremendous storm with huge winds.
Oh no.
Yeah. It is pitch black outside and the trees have stopped bending over. And I apologize. I don't know when I stopped, but.
That's okay. It was such a good presentation. And I was thinking he's only got another minute or two. So hopefully we didn't miss too much of it.
No, I think you got most of it. And I won't belabor the point. And I'm just glad to be back. I'll try to see if the video will work.
And I really hope we can have a copy of your slides because
they're online.
touched on some really, really good points.
Thank you.
Um,
They're available. Anybody who wants them can request them. I just ask that they go as a PDF and that they not be used for other people's presentations. But other than that, they're available, and I'm happy to discuss them.
Thank you so much. So, any of the panelists want to jump in, or as Kevin said, do I need to call on anyone in particular? Okay, Katie.
Thank you, Dr. Med, for that fabulous presentation. I completely agree with so many pieces that you said, both in my work with the Pediatric Environmental Health Specialty Unit, as well as my work with the Alliance of Nurses for Healthy Environments. I've been working with community members and individual patients who've been exposed to PFAS, predominantly through water contamination. And the thing that always strikes me is just how scared they are, and we really have to acknowledge that it's really scary, and that they feel like a lot of the systems in place, they don't acknowledge that fear, and they don't, they feel like they're dismissed by their providers. And I think a lot of that is just that the providers don't know anything about PFAS and, what they need to be looking at or tests that they need to run. And I think just as health providers, we need to be able to acknowledge when we don't know something, and that's okay. And I think that actually really builds trust with your patients by acknowledging when you may need to do a little research on something. And I think that there's a lot of opportunities to help educate providers. And I think it's, targeting education, especially in areas where we know now we're finding more and more PFAS contamination in water, and state nurses associations, state medical associations providing CEs around PFAS, or, looking for different ways where we can get primary care providers to have a more expanded level of knowledge. And that's something that my organization's been doing. We've had, I think we're coming up on our third CE webinar on PFAS, because there has been such interest within the nursing community. So I think there's a lot of opportunities to build trust with our patients and to expand the knowledge of healthcare professionals.
Thanks, Katie. Vida? Okay.
Yeah, fascinating talk and so helpful to this discussion. And from our clinical experience in the Region 2 Pediatric Environmental Health Specialty Unit in the New York State Children's Environmental Health Centers, we think it's really important to recognize that this predicament that we're in as a result of the failure of industry to assess the full impact of chemicals on the environment and human health before their widespread use. And because of this failure to do this critical work, the burden of responsibility is unfairly shifted to families, communities, public health agencies, and the medical community to figure it all out. And this leaves families frustrated, stressed, angry, and left without answers that they need and rightfully deserve. And the medical community, by and large, is, as several have mentioned, Katie most recently, they're just not trained to address families' questions about emerging exposures of concern and what this means to human health. And so the anger is directed at both the healthcare professionals and the public health professionals, who are left with the hard work of communicating risks and tackling this difficult task of carefully explaining what we know, what we don't know, and the utility and limitations of clinical testing. And this is all in the setting which you so carefully outlined of the existing current guiding clinical principles for healthcare professionals, which is rooted in whether a test will change clinical management, and two, in ensuring that we cause no harm. And these are important principles that have really been discussed at length by past speakers, and I and my colleagues at Region 2 PACU wholeheartedly endorse. However, in areas of uncertainty, it's especially important to carefully explain risk, benefits, and potential harms of testing, and ensure families do not get sent down a rabbit hole of non-evidence-based therapies and testing that could potentially be harmful, all in an effort to do something. And Our guidance to families is that the most important actions are to prevent and reduce any further exposures and then provide guidance steps they can take to do just that. And this includes using their voices to advocate for needed policy change and preventing the exposures from occurring in the first place. However, if families fully understand what questions testing from a reliable laboratory will answer and their limitations, then decision about testing in highly exposed communities potentially becomes one of individual choice. And one important question to consider is whether knowing the burden of exposure through biomonitoring and being able to place those exposures in the context of other highly exposed populations addresses the acute and chronic health effect of toxic stress that many families and communities bear after exposure. And in navigating these decisions, it is so important that families fully understand the risk benefits and likelihood of informing clinical management, and that they are fully informed about potential harms, including potential harms and costs of testing and non-evidence-based therapies. The current resources to address these clinical concerns are finite and cannot at the current funding level or structure meet the needs of the many communities that are impacted across the United States. And additional training is needed, especially of a pipeline of experts who are able to effectively communicate risk to families and can also work to educate the medical community. And primary care clinicians need readily available clinical tools developed together with community partners so that the busy clinician has them on hand. And this can inform counseling during that short clinical visit. And at our PACU and Nice Check Center, we've developed tools originally created by the American Academy of Pediatrics, Physicians for Social Responsibility in the Region 9 PACU called Prescriptions for Prevention. And it boils counseling down into 3 key messages, which are what, so what, and now what. So we define the problem, why are we concerned, and what can you do about it? And these are tools that can be readily integrated into electronic medical records and tailored to local community resources and referrals. And so my question for you, Dr. Duckett-Min, is that I was really glad to hear you speak about the stress placed on families. And there's a smaller body of research looking at stress on families and communities from placed on families from exposure, specifically as a health outcome, as well as how stress can magnify risk of adverse health outcomes. For example, adverse birth outcomes. And so what are your thoughts on utility of clinical testing in mitigating acute and chronic stress from exposure?
Is Alan still here with us? Maybe we had that storm in Northern Virginia yesterday. I was coming home after an 8-hour flight, and it was not pretty. Hold on to that thought, Maida, and we will, hopefully he'll be able to join us again, and we'll ask him that question. Dr. Reed, did you want to reflect a bit on the presentation and maybe share your own perspectives?
Yeah, thank you so much. It's really an honor to be here virtually with everybody. This is actually the first time I've been involved in a PFAS activity or meeting. I was asked to be a part of the panel because I was approached by one of my patients regarding testing, who's involved in PFAS research and activism. I had never heard of it. I was not aware of it. This was only probably about 9 months ago. And so I was invited to be part of the panel just as kind of your typical bread and butter workhorse primary care provider who's seeing 20 to 25 patients a day, doesn't know anything about PFAS, and curious how far the rabbit hole goes with this. I think it's common sense that ever since the Industrial Revolution, we've been making all kinds of synthetic compounds and chemicals that we were never exposed to, we never interacted with in our evolutionary history. And obviously it's a huge Pandora's box in terms of the impact on health. And this is a great example, a very specific example, working with PFAS and PFOA. So, speaking from my own perspective, I was open to ordering the test, even though I hadn't heard about it, because my patient was somebody who was very knowledgeable about PFAS and was connected with all the resources, knew much more than I did, honestly. It's quite humbling. And I was frank with them and upfront. I said, look, I can order the test for you if you want to, if you're curious about the results, but I don't know how to interpret them. I don't know what to do with them. I don't know who to send you. You know, if you can figure that out, then I can order the test. So this was my opportunity to learn more about how to handle this aspect of clinical care. Some thoughts that I have would be, you know, the clinical guidelines that we have talked about a lot during this meeting so far. That would be really helpful to have a universal set of guidance on who to test, when to test, how to interpret the test results, what the management is, follow-up, treatment, medications. Hi, Dr. Deckerman. Glad to have you back. And then referral as well. You know, if there's some kind of specialist, because oftentimes in primary care, we'll get the ball rolling with something that we don't really know well. And if there are positive findings, then we'll ask for help from the specialist. But I only know of one clinical toxicologist in all of Los Angeles. And they usually deal with acute issues, acute intoxication, and not so much with chronic exposures over decades that can impact health and harm health. So those are some of the limitations that you know I would run into from the kind of the front line, and that would be probably the most helpful type of resource to have for us.
Okay. So Alan, I'm so glad you're back. I was saying I live in Northern Virginia and we had that storm yesterday and it was really scary and really bad. So I appreciate your tenacity in coming back. Did you want to respond to Stu or Dr. Reed's reflection? Couple key points that you made in your presentation, Alan, that I want to hold on to as we have this conversation, and then we'll open it up for questions from the committee. You talked about primary, secondary, and tertiary levels of prevention, and that there's different things we can do across those levels. You talked about teachable moments, and you talked about the systemic issues, right? That it's not just about sort of the clinic visit, because let's be honest, most of us don't see a clinician every year. And so we do have the need to train and educate clinicians on risk communication and all those things that were outlined, the universal guidelines that Stu talked about. But did you want to, just take the next minute to reflect on some of that? And then we can open it up to the committee for some questions for the panel, as well as for you, Dr. Deckerman. It looks like you're moving us somewhere else. Oh, and you're on mute. You're on mute.
I'm moving under a beam.
Oh, good. Oh my gosh.
Can you see how dark? Can you see how dark it is in here? But anyway, it's a wall of water and repeated lightning, but important business. I obviously didn't hear those questions.
Okay.
So the one thing to reiterate is that when Dr. Baker was talking, I was thinking about the almost 99% confluence that I had with his experience. For those of us who actually have exposures to patients, okay, who have these concerns, or to communities where there's lots of contamination. And Laura, I know you have it too. You have that experience too. The whole emphasis on how risky it is if we communicate the evidence to these folks, that has turned out to be very destructive evidence, very destructive emphasis. And it's destroyed trust. It's destroyed trust between clinicians and patients. It's created patient frustration. And I'm sure that trusted entities can regain the trust of the most affected communities, but regain is the emphasis that needs to be made, because there has been some loss of trust, and it's not intended It's just that for whatever reason, let me go back in time. When I was with the Board of Scientific Counselors for ATSDR, they used to give an annual lecture on the rules of the art of health communications. And as one looks at many of the health communications to affected communities or to whoever they're intended for, or to clinicians right now, it's almost as if there was a goal to tick the boxes of all the things that ATSDR told us 15 years ago to never do because they would lead to trouble. And that part of this problem is easy to fix. There's lots of things about PFAS that are really hard to fix. What do you do? How does what you would do differ, or should it differ from what you would do anyway? Those are very difficult questions. But the idea that we have no answer to the PFAS exposure because you have other risks, or because we can't pin the tail on the PFAS donkey because it doesn't have what clinicians call a pathognomonic outcome, the way that asbestos relates to mesothelioma. That's just not true. That's not right, even public health. And so there are easy things that I think this committee will certainly accomplish. And I'm guessing that it will also accomplish some of the really harder things as well.
Awesome. Are you still there, Alan? Oh, I think we might have lost him. Oh, no, here he's back. There is a question that was sent to you via chat. It was asked when you left us one of the first times, and it's from Dr. Galvez. Can you see that, Alan?
Yes.
Okay.
Yes. Yeah, I mean, there is no direct link between either PFAS testing or clinical outcome testing and reduction of stress. But I infer that it exists. People want that testing. And for those of us who actually have this experience, and that's probably 20 or 30 people in the US, and certainly Dean Baker is among them. The ability to get the testing is really important. And more fundamentally, barriers in the way of that testing are really problematic. And that's the better way to state it. When there are barriers to that testing, people don't do well.
Yeah. Thank you. I'm going to open up the question and answer time period now for the committee members. And if you could raise your hand, that will help me. There's a lot of Dean Baker.
Okay, good, thank you. So this is just a quick comment. I think Alan's points were outstanding, and I think I particularly like the last one about the systemic approaches, because I mentioned there's like the science that's talking about the certainty, and then it jumps all the way down to the individual clinician. And I would say there's something in between, and maybe there's a role, whether it's for PACU type of organizations that are in part supported by the ATSDR, the New York State, or local health departments. But the part of the issue is who and how will support be provided to the clinicians about communicating with these issues. And the systemic stuff really do have to do with, particularly when you focus, like Alan mentioned, on the contaminated communities, the value of having a formal structure for community input and participation, and having advisory committees, and the inevitability of what I call the aggregate data. I've been involved in several so-called ATSDR and EPA supported projects where we're providing services to communities within a year, within 2 years. Everybody wants to know the aggregate data analysis. So I just want to put a pitch out there to the epidemiologists on this committee to speak up for yourselves. There's a role for epidemiology in the clinical context of having standardized protocols, but also data collection, so you're not dealing, frankly, with a bunch of trash. So that when it comes time for that inevitable call, request by the community or by the governmental authorities, well, what did you find in this community? That you actually have confidence that at least the data you're providing are reliable and valid. Decision makers and community members will have to decide what to do with that information. But too many times, the gap between it's not an epidemiological study, therefore we don't have to pay any attention to quality assurance is really sad, and it comes back and bites people all the time.
Dean, thank you for that. Strong agreement. And let me add one thing. In my other research area where I do quality improvement research with pathologists, the idea that if you collect data, it's research, which we hear whenever we talk about collecting data on behalf of communities with medical screening, the accusation that we're trying to do research. No, that's not true. We understand research and the funding and the intricacy it takes. This is really about quality improvement and making sure that the monitoring, that the screening program is directed at the needs of the community and addressing the needs of the community. And that takes some doing.
I have a quick question, and then tomorrow I will call on you. Both Alan and Dean, based on your past experiences, there's, I know you're aware of this, it's called environmental public health tracking, which is, hosted by CDC. If that was well funded, do you see that as a mechanism that might be able to do some of this screening and surveillance and tracking over time?
Yes,
Yeah?
Laura, the question went away, so I won't try to answer it. Maybe Dean can, maybe
Okay,
Dean or Dean can
okay.
answer it.
Sorry, I just have to turn it on to say I don't know.
Oh, okay.
My impression, both as a long-term alumni of CDC from decades ago, but also the recent news, is they have lots of good programs and lots of ideas that are vastly underfunded.
Yep.
So whether it could actually function in that way, or whether they should more likely focus on the guidelines and the programs along with ATSCR and try to delegate that to more local. That's why ATSCR developed the regional network of PACEs. I don't mean to keep plugging PACEs, but there are groups like that where you have some vetting of clinical and scientific expertise, but they're also more closely associated with the communities. There's also state and territorial health officers, and if you look at them, there's affiliated ones where there's state level epidemiology. Mm-hmm. So CDC can provide, I think, a coordinating role with those, because I think that's also a capacity building issue for state and local health departments to be able to do this kind of tracking and advising on when data collection should be a little bit more standardized, because it needs to be ready for, I'll say, aggregate analysis and feedback. Yeah.
Great, thank you. And you can't overstate PACEs. Maida and I are both co-PI or PIs on it, so we know what you mean. All right, so Tamara, you had your hand up. Thanks for waiting.
I have two questions. I don't know if we have time for both. One is a clarifying question, because maybe I misunderstood, but Dr. Galvez, could you say a little bit more, because maybe I misinterpreted your comment or your question to be to be opposing the kind of conversation around kind of getting this information to the community and sharing it with the community from the kind of physician perspective. So I wanted just to kind of clarify that, because I know that there's many different opinions, different perspectives and views. And if that is your perspective, I kind of wanted to better understand that, in the context of Dr. Ducketman's presentation. My other question is perhaps a little bit of a follow-up to this conversation right now. So Dr. Huffling, I was just wondering if you could say more about what you think the role of the PACEs really might be in the context of kind of communication, health communication in this space. So two very different questions, one a clarifying question. Thank you.
Yeah, thank you for that question. I think what you're asking is, can we train the healthcare community to address these concerns in the clinical setting? And I think that's an excellent question. And I think it varies, quite honestly, by clinician and that clinician's willingness to take this on. And we see that with a range of environmental exposures where some clinicians are very willing to do a full lead risk assessment and the screening, whereas others refer patients to us for very low lead levels to provide the counseling and the assessment. So that varies tremendously across clinicians. I think that what we can do is for the motivated clinician who feels like they can address this, is to give them the tools that they need to be able to do that effectively and to be able to point those families to additional resources as needed locally. So I think I agree with you. It's a challenge and one that we need to chip away at, but also to ensure that we support the existing infrastructure to build the capacity to address those needs, but also build the pipeline of future experts who can also address those concerns moving forward. Thanks for your question.
I think with the PACEs, I think it's an underutilized resource. Since I started working with the PACEs, I've just been really surprised at the number of providers that don't know that this free resource is available. And I know the PACEs have been really active in looking at PFAS and providing fact sheets for patients and providers, providing webinars for healthcare professionals. I think, providing greater opportunities for more health professionals to know about these resources, I think is really key because I think one of the strengths of the PACEs is when you have a healthcare provider that, is confused or doesn't know what to say to their patients, we're a great resource that you can send those patients to, or we can talk with the provider so that it, helps their other patients. But it's just such an amazing resource that we have for not just pediatric patients, but women at reproductive age or breastfeeding women. It's a fabulous resource.
Thanks, Katie. One other, in addition to providers and families, is we've done town hall meetings where we speak to some of the concerns of the community to help sort of provide information and within the context of what we know. So thanks, Katie.
I see Dean Baker is holding up his hand.
Okay.
Yeah, just a quick comment. Thanks to people like Phil Landergan and Lynn Goldman and others, we have a PACU because we had an EPA Children's Environmental Health Program. We actually haven't seen that, and there's a lot of concern in communities, and I focus on this on children, but when we have things like immunotoxicity that may occur in adults and kidney cancer, and there's a whole world out there in terms of the other end of the developmental spectrum where we're going to focus more and more on longitudinal impacts on neurological decline in the elderly. They really need the equivalent of a PACU for populations, for adult populations as well. Maybe that's because I trained in family medicine. So I'm always concerned about both children and adults, and we focus a lot on children, and we should, but we also have vulnerable adult populations, and we need that kind of organization or communication that can occur broadly for the population.
Thank you. Are there any last questions? We have 40 seconds left. I really want to thank the panelists and Dr. Duckerman. Some really great pieces of information that we'll be able to use as we begin to look at creating those clinical guidelines. And
Thank you. I want to show you what's happening. I don't know if you can see it.
I can see it, and luckily I don't see a tornado. I'm from the Midwest. That's the
we have a warning, but so far it's all quiet.
All right. Well, you might want to get in the basement when we're done here. Protect yourself. Okay. I think that's it for me, and I'm not introducing anyone. I do not believe, Ned. So thank you again so much to the panelists and to Dr. Duckerman.
Thank
I would
you.
add my thanks as well, and I know I'm speaking for all the other members of the committee. Thanks so much for everyone's time. We're now going to begin our public comment period. There are a number of people who signed up in advance, and that's the way we do public comments. It's hard for me to tell with the numbers on the screen of who I have, so I'm going to kind of move through the list. We will use Zoom security features to keep folks at the 3-minute time limit. Speakers will be asked to unmute themselves when it's their turn, and then mute again when your turn's up. We're strict about the 3-minute time limit in terms of being fair to others who've spoken and who will speak in the future. We encourage the public to send any written material relevant to our charge to the National Academies staff. And when you do, please include your name and contact information for any written materials. The first name I have on my list is Matt Ferguson. If you're on, could you unmute? Okay, next I have Kajap Thakori. Next I have Sharon Browning. Next I have Ellen Kuo. Next on my list is Priyanka Gunasarka. Then Zaid Holloway. Peggy Sprague. Ralph Dammel. Alicia Buchanan. Aslam Mashi. Margaret Temple Brown. Joseph Samuels. Mary Frances Bruckmeyer. Judith Miller. Miriam Perez Cordova. Teresa Calhoun. Joan Murphy. Finally, Crystal Saika. I want to just assure our panelists that it is not unusual for folks to have signed up ahead of time, and then we assume life gets in the way and they were unable to join us with their public comment. And again, we encourage all folks to send us written comments as possible. Elizabeth does consider all of those. She shares them with the committee, and we use them in our deliberations. So we're almost exactly on time. Let me remind folks that we have another session tomorrow. And the session tomorrow is going to focus more on strategies for communicating biomonitoring results and the opportunities and challenges with connecting biomonitoring to clinical care. So we're excited about that session tomorrow. It'll start at the same time, which I think is, I'll get it wrong, 1 o'clock Eastern time. Elizabeth, I wonder if you have anything for the end of the session today.
No, not particularly. Just that I want to thank all the speakers and panelists for your discussions today. It was really helpful to the committee. And thanks to all the committee members for participating. It was a great discussion.
I'm going to let everyone go exactly 3 minutes early. That never happens. And we'll see everyone tomorrow. Looking forward to those sessions and discussion as well. Have a great rest of your day, and bye now.